this is a review article that focuses on the higher risk perioperative conditions. We look at both cirrhotic and non-cirrhotic liver disease, inflammatory bowel disease, and also touching on something called PONV, or postoperative nausea and vomiting, and also the risk of ileus in the perioperative setting. And then we go on to talk about management of patients with end-stage renal disease who are on either peritoneal or hemodialysis. My name is Karna Sunstead, and I'm an assistant professor of medicine and consultant in general internal medicine at Mayo Clinic, Rochester. I practice both internal and perioperative medicine. The title of our article is The Preoperative Evaluation and Management of Patients with Select Gastrointestinal, Liver, and Renal Diseases. Within each of these conditions, the manuscript in our presentation first talks about the altered physiology in the perioperative setting. Now, that's not the focus of the article, but I think it's important to understand as we manage these higher risk conditions. Just an example, thinking about how surgery affects the gut. There's release of catecholamines and neurotransmitters that can impact the chemoreceptor target zone or trigger zone within the CNS, and that can result in PONV, and then also impact gastric emptying and cause gastric delay. And then we get into the question of the effects perioperatively. So predisposition to ileus can even affect absorption of certain medications. So that's an example of the altered physiology in the perioperative setting. And then the article goes on to discuss a preoperative evaluation. So what labs are useful and potentially change management in patients with these select conditions? And are there any additional tests or even interventions that can reduce risk? One of the questions that often comes up in our cirrhotic patients, what about tips for reducing perioperative risk of mortality and other cirrhotic related complications? And there just isn't evidence to support that. So the article discusses some of those key interventions that come up as questions. And then the third part of it is optimization. So what measures can we take preoperatively to reduce these postoperative complications? It could be something as simple as the timing of hemodialysis in our patients with end-stage renal disease, or it could be optimizing hemoglobin levels through iron transfusion and EPO-stimulating agents in patients with kidney disease. So those things that can impact risk and optimize the care. And then the last part of it is recognition and understanding the very common complications of surgery or from surgery in patients with these conditions. I'm going to pick on cirrhosis a little bit, which is one of the higher risk conditions we manage. And cirrhotics have a long list of potential complications that need to be on the radar screen, even if we're not doing anything preoperatively. For example, they have both increased bleeding and thrombotic risk. We need to monitor electrolytes very closely, sodium in particular as an example. They're at risk of fluid retention. Some require therapeutic paracentesis in the perioperative setting. Certainly encephalopathy as we put them through the systemic stress of anesthesia, medications, and the hospital environment, and then how to manage medications. So the article discusses pain management in cirrhotic patients, the use of short-acting medications, and what opioids tend to be preferred, although we should certainly be minimizing most opioids. So within each of the conditions I talked about, there's a discussion in those areas. And then in terms of clinical practice, I think this review gives a nice synthesis of management of the higher risk conditions, and it's in fairly palatable format and hopefully something that's usable for a busy physician, a busy perioperativist. For example, with liver disease, We have a number of tables in the article that summarizes, so what are the acute and chronic liver conditions that should be on the radar screen. Cirrhosis is a common example, but then there's also things like NAFLD or non-alcoholic fatty liver disease. What about the patient with autoimmune hepatitis? So there are those other conditions. And then we talk about preoperative testing. So these are patients that require expanded laboratory studies. The tables then cover the risk stratification tools from the MELD score to the CTP or Child Turcotte Pugh score to the Mayo postoperative surgical risk calculator. And there's a discussion about what are the inherent, strengths and weaknesses of these calculators. As clinicians, we need to be aware of that and I think apply it correctly. And then we go on to talk about the risk stratification. Here's an example. In patients with a MELD score less than 10 or CTP of A, usually they can proceed to elective surgery and do okay. Conversely, patients with severe or advanced cirrhosis can have nearly 100% risk, 100% mortality risk at 90 days. So then we get into, the goals of care and some of those difficult discussions. And then what are the specific surgeries associated with elevated perioperative risk in the cirrhotics, like intra-abdominal surgeries? So these are some of the tables contained in the articles that we hope to be fairly quick references. In terms of what this means for patients, I guess it all comes down to that. So ideally, we want to get complex patients to and through surgery, including in the post-operative setting, even up to 30 days. We want to reduce the risk of complications. And a lot of times that comes through a thorough preoperative history, identification of high-risk conditions, and then I think as important, we want patients to go into an important surgical decision understanding their risk. We don't want there to be any surprises, and that's where the preoperative risk stratification and counseling becomes important. And I think as we approach multidisciplinary care, it's important for patients, but also surgical colleagues as they consider some of the higher risk surgeries. In terms of what's on the horizon, and I think where there may be some gaps in research, there are a lot of interventions we do that are standard of care and certainly make a lot of medical sense, but we don't yet have outcome data for all of these interventions. So answering the question, do they reduce mortality, length of stay, other surgical complications? So I think that's an area ripe for research and more to come on that. So in summary, the article reviews the preoperative evaluation through to perioperative management and postoperative complication management of patients with select and especially relevant conditions and high-risk conditions in the perioperative setting. This includes inflammatory bowel disease, PONV, ileus, end-stage renal disease, and both non-cirrhotic and cirrhotic liver disease. Of course, with the ultimate goal of utilizing a multidisciplinary approach involving surgical and anesthesia colleagues, as well as our subspecialists, to facilitate and really produce a very successful surgical result with as few medical complications as possible.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.